Hello guys, my name is Felipe. I'm a Brazilian neurologist and today's lecture will be about suspected acute encephalitis. When we're talking about encephalitis, we're talking about a process of inflammation of the brain parenchyma. It is divided in two main categories, infectious encephalitis and autoimmune encephalitis. It is defined by a subacute alteration in mental state and plus additional features such as fever, seizures, and focal deficits, and so on. I'll be discussing later. Its incidence is about 4 to 12 each 100,000 people globally, being the herpes simplex virus the most common form of infectious encephalitis. About the clinical picture of encephalitis, we have the major criteria and we also need two minor criteria, being the major criteria, subacute or acute onset of altered mental state, and we also need a collateral story from the neighbor, familiars, friends of the patient that will elucidate better for us. So, alterations in behavior, personality, amnesia, confusion, and coma, and so on. And two minor criteria of this main 5. Fever above 38 degrees, seizures, focal neurological deficits, pleocytosis in CSF, and MRI with acute abnormality. If the patient presents to us with focal neurological deficits, seizures, and clusters of especially psychiatric symptoms, we'll be thinking about highly suspicion of autoimmune encephalitis. If the patient presents to us with déjà vu, olfactory hallucinations, and amnestic syndrome, this points towards a temporal lobe or limbic system encephalitis, especially herpes simplex virus, but also some kinds of autoimmune encephalitis. If the patient presents with acute onset, we will think about herpes simplex type 1. If the patient has a subacute onset, we will be thinking about autoimmune limbic encephalitis. If the patient has facial-brachial or diastonic seizures, this is pathognomonic of LGI-1 antibody autoimmune encephalitis. If the patient presents to us with Morvan's syndrome, that is a triad of CNS dysfunction, autonomic disturbances, and peripheral nerve hyperexcitability, this is suggestive of CASPR2 antibody autoimmune encephalitis. And when we talk about the NMDAR antibody encephalitis, we're talking about a more prominent clinical picture of psychiatric symptoms, being them delusions or hallucinations, movement disorders such as orofacial dyskinesia, dysautonomia, seizures, and coma. Obviously, the psychiatric symptoms will have to make the differential diagnosis with especially psychosis, but psychosis the patient will present to us with both positive and negative symptoms, and another alternative diagnosis will be catatonia for psychiatric symptoms. So, this syndrome is suggestive of NMDAR antibody encephalitis. It has association with ovarian teratoma and has a proportion of 4 females to 1 male. If the patient presents to us with cranial nerve palsies, ataxia, and hemiparesis, this is suggestive of brainstem encephalitis that we call rhombencephalitis. If also the patient has intractable vomits or hiccups, this is suggestive of area postrema syndrome, such as NMO. If the patient also presents with dysautonomia, that is labile blood pressure, this can point towards enteroviruses, such as enterovirus 71. Bickerstaff encephalitis usually will be preceded by an infectious trigger, and it's characterized by the triad of alteration of consciousness, ophthalmoplegia, and ataxia. It's associated with anti-GK1B antibody, and it's one kind of the brainstem autoimmune encephalitis. Other kinds of brainstem autoimmune encephalitis are MOGAD, IgLON5, GFAP, and other paraneoplastic syndromes such as HU, RI, MA2, KLHL11, and LUZP4, those antibodies. If the patient presents to us with rapid decline in consciousness, Parkinsonian tremor, and movement disorders, this is suggestive of anatomically lesion of basal ganglia and thalamus. And some etiologies for this, we'll be thinking about arthropod-borne viruses, such as Japanese encephalitis virus, West Nile virus, and Eastern equine viruses, and also other enteroviruses that can also cause acute flaccid paralysis because of lesions of the anterior horn cells in the spinal cord. ADEM, that is, acute demyelinated encephalomyelitis, is also preceded by infection or vaccination, and it has a clinical picture of the main characteristic of ADEM will be encephalopathy, multifocal deficits, and demyelination that happens both in white matter and spinal cord. 50% of the ADEM will be MOG antibody positive, that we'll be calling then MOGAD. If the patient presents to us with hemiplegia, cognitive deficit, and refractory focal epilepsy, this is then suggestive of Rasmussen encephalitis. In the workup of encephalitis, we need to order complete blood count, CRP, electrolytes, serologies, CSF initially. In the blood count, we will search for lymphopenia, suggesting viral infections, eosinophilia, suggesting parasitic infections. CRP is expected to be normal. That's because in CNS insults, the CRP is expected to be normal against systemic, in which it will be elevated. Hyponatremia can both suggest autoimmune and infectious encephalitis. HIV can be one of the causes of encephalitis, especially on the seroconversion. So if the patient has a new diagnosis of HIV, it can be one of the causes of the infectious encephalitis. In the CSF, when we're thinking about lumbar puncture, usually we will order a CT scan before performing the lumbar puncture, but some cases we will consider a contraindication to immediate lumbar puncture. Those cases are papilledema, altered mental status, midline shift, focal deficit, seizure in the last 7 days, and the patient which is immunocompromised or has that suspicion. In the CSF, we'll be watching for opening pressure, the biochemical exams, such as proteins and cells. If the patient presents with pleocytosis, that is neuroinflammation. Then if the patient has elevated neutrophils, can be an early viral. If the patient has elevated lymphocytes, that can be both viral and autoimmune encephalitis. If the patient has elevated eosinophils, that can suggest helminthic, fungal, or mycobacterial infections. If the patient has elevated red cells, that's suggestive of herpes simplex virus type 1 or acute hemorrhagic necrotizing encephalitis. When the patient has more than 1,000 cells, red cells, that's when we call it traumatic lumbar puncture. So we have the correction factor of 2 white cells to every 1,000 red cells and 0.01 grams per liter of proteins each 1,000 red cells. If the CSF is normal, that doesn't exclude autoimmune or infectious encephalitis in the first glance, because 1/3 of the patients will have normal CSF. Then we should repeat it 48 to 72 hours later. Also, we will need oligoclonal bands in the CSF, microbiology such as grain stem and culture, and PCR for viral panel that needs to have at least herpes simplex virus type 1 and 2, varicella zoster virus, and enteroviruses. If all these 3 are negative, we will need to question, was it in the early days of illness and was it after acyclovir? So if yes, we will need to wait 48 hours and repeat CSF and add some atypical antibody testing. And other tests that we will have to order in the CSF will depend on the situation. If the patient is immunocompromised, we have to order Epstein-Barr virus, CMV, cytomegalovirus, and human herpes virus type 6 and 7. If the patient is child, we have to order adenovirus, rotavirus, influenza A plus B, and think about measles, mumps, and chlamydia. If the patient has exposure to rabies, West Nile, Japanese encephalitis, and tick-borne, so we order them in the CSF. Beyond the CSF, we will also need to order blood and CSF cultures, especially for Listeria monocytogenes. That is one of the etiologies of rhomboencephalitis. MTB expert for TB, searching for Mycobacteria tuberculosis. Antigen tests such as cryptococcus. And if we're suspecting of autoimmune encephalitis, the CSF has high specificity and the serum, the blood, will have high sensitivity. The autoantibody panels will help us to determine the diagnosis then. In the neuroimaging, our main modality will be MRI. There we have two scenarios here: parenchymal inflammation and normal or non-specific alterations. If we are suspecting of antibody-negative autoimmune encephalitis, or the patient has normal and non-specific alterations, we can be ordering then FDG PET-CT. If the patient has a known tumor, then we also need to order the body PET-CT. The EEG will also help us searching for encephalopathy, non-convulsive or subtle status epilepticus, and extreme delta brush, which is characteristic of anti-NMDAR antibody encephalitis. Other exams will be PCR for influenza, chlamydia, COVID. The brain biopsy will be ordered when the patient has unexplained and refractory brain inflammation, or we have active suspicion of malignancy. The management of infectious encephalitis will start with empirical acyclovir 10 mg per kilogram of ideal body weight of the patient each 8 hours, ideally within the first 6 hours of the admission, but not further than 24 hours. That's the maximum. We should adjust to renal function and continue if PCR is positive, and continue if the PCR is positive for herpes simplex virus type 1 or 2, and varicella zoster virus. If the patient has varicella zoster virus, we need to adjust the dose of the acyclovir to 15 milligrams per kilogram of ideal body weight each 8 hours. If the patient is immunocompetent, we will keep the acyclovir for 14 days, and if the patient is immunocompromised, we will keep the acyclovir for 21 days. If the risk-benefit is favorable, that is, the patient doesn't have great risks such as compromising his renal function or stuff, then we can consider keeping the acyclovir until the CSF PCR goes negative for HSV or VZV. And if the PCR is positive for other viruses, then we should stop acyclovir and consider other therapy. The supportive treatment of encephalitis can be hard, especially with brain swelling, but we can, for this, start corticosteroids, osmotic agents, and elevate the head of the patient until 30 degrees. For autoimmune encephalitis, the first line of treatment is immune therapy. The patient needs to have negative PCR and cultures, needs to have positive antibody, and suggestive neuroimaging. We will be starting with high dose of IV methylprednisolone, that is 1 gram each day for 5 days. And or after the methylprednisolone, we can consider plasma exchange and or IVIG. The second line of the treatment for NMDAR antibody will be rituximab. Some cases will be suggesting cyclophosphamide. We need to actively search for ovarian teratoma, then perform the surgery if present. And if also refractory, that questionable in the literature. But tocilizumab and bortezomib have been studied. If the patient has LGI1 encephalitis, probably he will have a great response to methylprednisolone, so most cases will have a good response. If the patient has paraneoplastic encephalitis, it will respond poorly to the immunotherapy and will have a good response to surgery. The treatment of antibody-negative autoimmune encephalitis is controversial, but some cases can suggest immunotherapy with some evidence of improvement. But we need to first see the improvement, so we'll have to make some cognitive testing, EEG, MRI, and if there's some actual evidence of improvement, then we can proceed to more aggressive immunotreatments. The maintenance therapy varies. For NMDAR antibody and LGI1, they have a relapse rate of 12 to 35%. Then we can consider repeat courses of immunotherapy. If the patient has an encephalitis relapse weeks after HSV encephalitis, 1/3 can be NMDAR antibody positive. And that does not necessarily mean that he has autoimmune encephalitis. And some cases of relapse will be or persistent viral replication or post-infections autoimmune syndrome, usually mostly related to positive NMDAR antibody, and its clinical presentation will be choreoathetosis with or without other abnormal movements and behavioral or psychiatric symptoms plus acute psychosis.